Duncan, thanks for the introduction. Hope everyone can hear me perfectly fine. I think Duncan introduced me really well. I'm a medical student who's been working at ICORD for the past 2 years. And Duncan called me one day and said, "Hey, do you want to do this?" And I said, "Yeah, no, it's super interesting because one day I would like to become a urologist." So super honored to be able to speak with all of you who have such a vast experience with spinal cord injury and speaking in these discussion groups. But I guess I'll get going. So quick introduction. Yes, I worked at ICORD, interested in urology. I've published a few recent papers related to Botox, as well as autonomic dysreflexia in the context of urological procedures. So this is something that I am indeed very interested in. I would just like to preface by saying that I'm not a medical doctor. So any advice that I'm speaking about, don't take it as medical advice. This is simply a discussion that we're having together. But these slides have been looked over by Dr. Krassioukov, who I'm sure most of you have probably met already. So just an outline, as Duncan said, I'll give a brief introduction to something that all of you are quite familiar with, spinal cord injury and the urinary system. Then we'll talk about some key changes to the urinary system that occur with aging and spinal cord injury, as well as management and strategies that you can employ looking forward into the future and answering some of the questions that you've had previously. So as I'm sure you're aware, the urinary system is compromised after spinal cord injury, and cervical spinal cord injury is the most common type of spinal cord injury, with about 50% of all cases occurring in the cervical levels. And what this results in is something called a spastic bladder. So your bladder is very reflexive, you have a very low capacity, and there's a lack of coordination between your bladder and the sphincter that impairs your ability to hold and also expel urine. And this can be quite detrimental for people with spinal cord injury, especially as you grow older. And these are just a list of the complications of neurogenic bladder. As you know, urinary tract infections, urinary tract stones. You can get kidney injury due to your bladder not being able to empty, and the pressure can transmit the water to your kidneys, which can be damaging over a longer period of time. Autonomic dysreflexia in those of you who have a spinal cord injury above the thoracic sixth level, as well as bladder cancer. And bladder cancer in the SCI population is 16 to 28 times more likely to happen. And we'll talk about this later in my presentation. Now, in the general population, there are changes that occur to the urinary system with age. And just focusing on the left side, our bladder tissue becomes stiffer as well as thicker. The bladder loses nerve supply over time, and overall, you can't store as much urine. However, there's very little information on how our bladder tissue changes with spinal cord injury and aging. Because as you know, I think that more and more people living with spinal cord injury are living longer and longer. And this is a very new area of research that not a lot of work has been done. But aside from the bladder, if we look on the right, some other changes to the urinary system, your kidneys are less able to handle and filter your blood to produce urine over time. And in men, by age 80, more than 90% of men have an enlarged prostate, and this can also impact our ability to urinate. And in addition, we have an increased incidence of infections, UTIs, stones, kidney, bladder, and prostate cancers. So that's my introduction, but I'm just going to talk about some of the questions that you have spoken about with each other 2 weeks ago, and I've kind of categorized them into 6 main areas. So the first one would be, in general, how can we maintain our bladder health as we grow older? And then how can we prevent urinary tract infections? What are some strategies that we can help with transferring? Maybe we need to make different choices about the types of catheters that we use. We'll also talk about bladder cancer and some areas of research that I'm involved in terms of newer therapies that can help with our bladder function. So starting with keeping a healthy bladder, as we age. I think that all of you are probably aware that the best ways to keep a healthy bladder is to do things that are not unique to only having a spinal cord injury. I think everyone should avoid smoking whenever possible. You need to be drinking plenty of fluids so your kidneys are working continually and they're not deprived of blood flow. You want to maintain a healthy diet and also keeping up some forms of physical activity. And I make the reference here to pelvic floor muscle exercises, but when Duncan and I were reading over this presentation, he explained to me that many of the audience is not able to actually perform pelvic floor muscle exercises. I will just explain that if any of you have an incomplete injury and are AAS C or D, if you haven't already been performing pelvic floor muscle exercises, this is something that could potentially aid in helping train your urinary tract and bladder, which could help keep it functioning longer over time. Now, if you're unable to perform pelvic floor muscle exercises, I think in general, it's good to try to maintain some kind of physical activity, whether that's doing cardiovascular activity, working out your upper body, or maintaining a healthy diet, because the lighter that you are, the less weight that is actually pushing down on your bladder. And that lower amounts of pressure will help keep it functioning for longer. So that's just something to keep in mind. There was another question about D-mannose, and I just wanted to talk about this because urinary tract infections are more common as we get older, and they're also more common in the spinal cord injury population. However, little research has been done to see if both spinal cord injury and aging contribute to an even higher incidence of urinary tract infections. So right now, to prevent urinary tract infections, the American Urological Association only recommends that you should be using antibiotics if you're over 70 and you're about to undergo a form of surgery, urological surgery, or if you have risk factors like you're a heavy smoker or you may be living with diabetes. Otherwise, there's not much that you can really do to prevent urinary tract infections aside from making sure that you wash your hands, making sure that you wash your pelvic region, and making sure that you maintain a bladder routine. But there are some medications that you could choose to take for day-to-day management of urinary tract infections. D-mannose, which is a sugar, cranberry juice or cranberry pills, and vitamin C. These are all thought to help prevent and treat UTIs. And what they do is they prevent bacteria from binding to the urinary tract wall, so the bladder wall. Now, it is a little bit controversial, is that these substances in research, they report conflicting results. Sometimes they've shown to work, sometimes they haven't shown to work. But I think what is important to note that overall the side effects of taking these are quite low. And just some things to note, if you look in the top right of my screen, D-mannose, I think there was a question, what kind of bacteria does it prevent from colonizing your urinary tract? D-mannose blocks a lot of bacteria, E. coli, which is the most common cause of a urinary tract infection, as well as these other bacteria names, which are very long and hard to pronounce. I don't expect you to have known them already, but just going to say that D-mannose is pretty effective in blocking kind of the most common bacterial causes of infections in the bladder. Maybe some other questions that you might have had, or if not, I'm just going to say them. If you are taking cranberry juice, you should speak to your doctor about this, but it has been shown that it could cause bladder stones, or if you're on any anticoagulant medications, there could be some interactions. Maybe a question that you had, D-mannose itself is a sugar, but if you have diabetes, you actually don't need to worry about taking D-mannose. It's not going to make your blood sugar any worse because it doesn't interfere with your blood sugar regulation. And just to note that D-mannose can cause diarrhea as a side effect if you take too much of it. So transfers, with age, your ability to transfer could become more difficult, and improper transfer can lead to changes in your shoulders. You can get shoulder damage, and you can also increase the risk of your falls. And there isn't a lot of research that has been done on what kind of transfers can we implement as we grow older. But I would say that if you haven't already, that exploration of having care aids to help you with your transfers or using a transfer board Maybe you don't use a transfer board to transfer to the toilet, and you just make use of holding on to like handles or any nearby stable objects. If you're getting older, maybe the use of the transfer board could help alleviate the shoulder strain that you're having from lifting yourself off your wheelchair onto the toilet. If you're ever needing to use the toilet to perform your bladder or bowel management, for example. So next, we'll just talk about catheterizations, and I'm sure you're aware there's a lot of different catheterizations options available for people with spinal cord injury. If we had more time, I would have actually liked to kind of gauge the audience to ask what catheters everyone uses, just because then I can have a better sense of who I'm speaking with, but we don't have a lot of time for that. This is something that we could maybe talk about after my presentation. But I think some general factors to consider with aging and your bladder management routine is how is your current bladder capacity or incontinence? How is your manual dexterity? Are you able to perform intermittent catheterization? Regarding cognition and being able to remember how much fluid you've drank throughout the day when you need to perform intermittent catheterization to empty your bladder. Maybe you're someone who's prone to kidney stones or kidney infections. Maybe that means you need to use a different type of catheter versus another. And then not every catheter maybe is covered or maybe is available or practical or safe to use. So I'm going to go through each of these options as we go forward. So clean intermittent catheterization, you're using it four to 6 times daily to empty the bladder. I think the big advantage of CIC is that you're basically letting your bladder fill and then you're emptying it. So your bladder has a chance to stretch, shrink. And just like any muscle in our body, the more you use it, the longer it's going to function. So as you grow older, this is a strategy that actually can be employed to maintain your bladder capacity. And of course, you don't need to wear an indwelling catheter or a leg bag. So that's why CIC can be useful. However, I think that in older individuals, something that came to my mind is that you need to have sufficient dexterity to be able to perform it independently. And you also need to be aware of how much fluid you're taking in every day. Another thing I want to talk about is single-use catheters. And if you're someone who reuses your catheter, I think a lot of people do it. But reusing catheters can also increase the chance of bladder trauma, urethral trauma, as well as also infection. And catheters that were reused over 3 days had quite a higher microbial burden, as I'll show in the next slide some images. So in general, if you're implementing CIC, what you're going to want to have is proper technique. You're going to want to use single catheters. You're going to use proper lubrication. Petroleum jelly is not the best type of lubrication. And you also want to recognize symptoms of urethral trauma, because this is going to help you identify if you have a potential injury that could lead to an infection in the long run. So this is a study that was done by Dr. K's lab. And one of the postdocs, T.F. Miller, showed that on the top is images from a reused catheter of 3 days. It's a special type of X-ray microscope looking at the surface of the catheter versus a single-use catheter below. And you can see that after only 3 days, you do have this biofilm formation, which is essentially bacteria. And by reusing a catheter, you're introducing that into your urinary tract every day, which is something that you want to avoid. Of course, indwelling catheters, there's urethral indwelling catheters and suprapubic indwelling catheters. And the difference between the two is that with your suprapubic, you have to undergo a surgery where they're cutting just below your belt line, and then you're placing your catheter in there. And I guess that where that has major benefits is potentially because you don't have a catheter in your urethra, that's not as limiting towards sexual activity. Personally, I don't actually know the major differences between the two, and this is maybe something we can talk about afterwards. But this is also an option to consider if you don't want to have an indwelling catheter in your urethra. So a question that Duncan brought to me is clamping of a suprapubic or indwelling catheter to maintain bladder size. I think that clamping the indwelling catheter would keep fluid in your bladder, allow it to expand, similar to how we're doing with intermittent catheterization. So I wanted to look in the literature if this could actually help with your bladder size. And it's not widely studied, but I think what came out of this is that clamping your urinary catheter actually increases the risk of urinary tract infections, because what you're not doing is clamping it. I think you're keeping the fluid in your bladder for a longer period of time, and unless you're able to kind of routinely empty your bladder as you are in intermittent catheterization, that can just increase the risk of infection because there's just urine sitting in your bladder, which is not a good thing. In addition, another study found that clamping of a suprapubic catheter could help with preventing a relative decrease in bladder capacity. However, the change was not that meaningful and also increases the risk of UTIs. And this is a lot of data that I don't really have time to go through, but if there are any questions in the question period, we can revisit the slide. So essentially, from the research that has been conducted, clamping an indwelling catheter or suprapubic catheter is not recommended. A condom catheter is another option, and it has been shown that condom catheters have a decreased risk of urinary tract infections. And it is also good if you don't have the dexterity to be able to perform an intermittent catheterization, but you also have to be aware of managing the bag that your condom catheter is attached to, or if you have any skin irritation around the condom or the external catheter, if we're talking about in women. There's also a surgical procedure called a Mitrofanoff. I'm sure some of you have heard about it, but essentially what this is they take a portion of your appendix, or if you don't have an appendix, they take a portion of your large intestine. And what they do is they take that off and they basically make a artificial tube and they connect that to your bladder. And then they connect the other end to the outside of your abdomen around your belly button region. And what they do is that creates something called a stoma. And in order to empty your bladder, you have to catheterize your stoma rather than, for example, catheterizing your urethra in the other options. So there are some benefits, is that the catheterization of your stoma can be easier for a lot of people. It takes less time and it doesn't always require you to transfer. And I guess maybe this isn't for this audience here, but undergoing a Mitrofanoff does not impact your ability to become pregnant or to deliver a baby. However, some disadvantages is you have to make sure that the stoma is cleaned every so often. If you are of a larger weight, or if you have an inflammatory bowel disease, that can make the surgical procedure a lot more complicated. There's a very good link, and maybe I can share this presentation with you after, but this person catalogs their experience by undergoing a Mitrofanoff, and they have a really great description about what they went through and what was the recovery period like. So I suggest that if possible, you can look into this later if you're interested. So as I mentioned, bladder cancer is 16 to 28 times more likely to occur in spinal cord injury than the general population. And the presence of an indwelling catheter may be attributed to this increased risk. So the Canadian Urological Association supports the use of cystoscopy to assess a suspected bladder or urethral cancer, but not for the routine surveillance of bladder cancer screening and SCI. And the reason I put this here is because maybe you're wondering, well, if I'm getting older, my risk of bladder cancer is maybe higher. Why don't I get more cystoscopies to make sure that they're tracking, to make sure I don't have bladder cancer? And I think the truth of the situation is that cystoscopy has a very poor detection rate for bladder cancer. Typically what they recommend is that you only have a cystoscopy around you have a cystoscopy only if your urologist or your doctor senses that there may be higher risk factors, like if you're bleeding more, you're having more recurrent infections, you have changes to your bladder habits, and only then would they proceed with a cystoscopy. So annual cystoscopy is not recommended for detecting bladder cancer. I just would like to say that the number one modifiable risk factor to avoid bladder cancer is to avoid smoking cigarettes. The evidence out there that cigarettes leads to bladder cancer is extremely, extremely high. So if you do smoke, try to reduce the amount that you smoke or stop altogether. Another thing I would like to talk about is the use of Botox. And Botox can be used for more than just your face wrinkles. In fact, Botox can be used to help with your incontinence. And Botox is actually widely used to help people relax their bladder muscle, and this prevents their spasms, reducing their symptoms of frequency, urgency, and bladder capacity. In addition, Botox can be helpful to reduce the occurrence of bladder-caused autonomic dysreflexia in people with spinal cord injury. And this is some research from our lab showing that after the use of Botox post, there was a lot lower number of like neurogenic bladder events, but also autonomic dysreflexia during these bladder events. And then some new research that's being done in the field is different forms of stimulation to help with your urinary tract function. The first form of stimulation I would like to talk about is tibial nerve stimulation. And some of you may have spoken about this with your doctor, but what this is the tibial nerve is a nerve that runs down your leg. And what they do is they apply a needle or an adhesive pad to your ankle to target the tibial nerve, and then they administer electrical shock. And what this is supposed to do is to help with your bladder function. And how this works is it's because the nerves that go to your ankle actually also go to your bladder. And it's this really cool phenomenon whereby this electrical activity goes up this nerve and then can help with the nerve supply to your bladder. And overall, the side effects of tibial nerve stimulation are very, very low. So this could be something that you'd like to speak about with your doctor if you're interested. Just these graphs here are basically showing that this graph on the left, someone who had tibial nerve stimulation, by 4 weeks, they were able to catheterize a greater volume of urine. PTNS is tibial nerve stimulation, and SS is sfolifenacin, which is a type of anticholinergic medication, basically showing that tibial nerve stimulation was as effective as oral medication. In addition, they leaked a lower volume per day, and their quality of life increased 2 and 4 weeks later. There's other forms of stimulation that are being explored by research laboratories around the world. This includes sacral nerve stimulation, which is similar, except that in this case, they're implanting a device along your hip, which is closer to your bladder. In addition, there's epidural spinal cord stimulation, which this is an invasive spinal surgery procedure where they're implanting a device on the covering of your spinal cord to target the levels that go to your bladder. And in addition, there's transcutaneous spinal cord stimulation, which is a non-invasive type of stimulation where they're putting a pad on your back above the levels of your spinal cord that are supplying your bladder. So these are all currently newer avenues of research that could help in the future with optimizing bladder function, particularly as we grow older. And I'm just going to put a little plug about some of the work that we're doing in Dr. Krasioukov's laboratory. We're running 3 trials here that are investigating the roles of stimulation for bladder, bowel, and sexual function. So if you're interested, you can contact these 2 individuals via their email or Dr. K, or you can email me after and I can get you in touch. I would just like to make a note that depending on the trial that is available, there are age limits. So I know that in the ISRT trial, you have to be 65 or younger. And this is just because that the effect of the stimulation, we don't know truly how safe it is, especially in an older age bracket. So we're just wanting to have these in place for safety reasons. So I think just some general conclusions before we go into questions is the effects of spinal cord injury and aging are likely to accelerate the occurrence of bladder management problems, but this is a relatively unknown area of research that needs to be prioritized in the future. Right now, the best ways that you can keep your bladder healthy is to avoid smoking, drink water, eat healthy, exercise, and maintain a healthy weight. In addition, urinary tract infections are more common as you grow older, and the evidence of using things like D-mannose, cranberry, and vitamin C to prevent tract infections is conflicting, but side effects are low. So when in doubt, I think you should ask your doctor. I think it's also important to do an evaluation right now of your physical and cognitive abilities when it comes to considering your bladder management routine as you grow older. So are you able to transfer? How do you transfer right now? What is your hand ability to catheterize? How's your memory? Are you able to remember how much fluid you're drinking each day? These are all important into bladder management. Indwelling catheter clamping increases the risk of UTIs. does not necessarily help with bladder function. However, I think this statement needs to be kind of approached at an individual level. Truly, if you find that this has worked for you in the past, if you've done this, then I think you should keep going. And then there's ongoing research in new safe therapies to help with bladder problems like Botox and nerve stimulation. So that's my presentation. I hope I was speaking at an okay speed. If you have any questions, I think we're going to go into about 25 minutes of questions. So I'm happy to have a great conversation with all of you.
There were a few questions that came through while you were talking in the chat room. One of them was, do you have an understanding or do you know if probiotics have an effect on urinary tract infections?
That's a good question. This is something that actually is talked about in our medical school curriculum. Probiotics, I think the evidence out there is not that strong, but then again, probiotics themselves are not that detrimental. I think that probiotics can be important because basically you're maintaining your healthy intestinal and urinary tract bacteria, and that is supposed to help by basically preventing like invasive bacteria from colonizing. So that is the school of thought on why probiotics work. However, the evidence out there is going to be some supporting and some against, but the side effects are pretty low. So I think that taking probiotics itself is not a bad thing to do.
Okay, I've got another question here. I'd like more information about the trials. Okay, Lucas, can you leave your email online or with me? I've got it. So
Yep,
can I forward it to the group?
Yes, you can forward
Okay,
it.
got it.
I've also put it in the chat here. Heather said I've had a Mitrofanov. I'm
Okay.
wondering if Heather, you'd feel comfortable, maybe if you have anything to say about that to the audience.
Had it for about, I think, 5 or 6 years before it closed up. I had an unfortunate circumstance where I moved and I didn't have a doctor, and it just so happened that it was starting to heal itself because it was something that wanted to constantly heal itself. And I didn't see a doctor quick enough to keep it open. However, while it was open, it was a great way to catheterize. It was super easy. I could literally pee anywhere I wanted. I could pee out in the woods. Like, it was very convenient. However, like you said, if you have any digestive issues, it caused me to get twice as bad digestive issues, which I still have to this day. So that was a big drawback. And it just so happens that that surgery left me paralyzed as well. But that could just be a me situation. I don't know that it had anything to do with the actual surgery itself.
Okay. I would like to say too that one of our staff with SCIBC, one of the peer coaches, Olivia Ray, has had a Mitrofanov, and she has actually gone on YouTube and put up a video of how she uses the Mitrofanov and how easy it is to do. And of course, she hasn't had any trouble with it yet, so it looks good. I do know, and I have a question for Lucas. I know that the suprapubic catheter is a very simple operation that doesn't take very long at all, but the Mitrofanov is a fairly major surgery, is it not?
It is a fairly major surgery.
And does it depend if you have your appendix or not?
No, because if they don't have your appendix, what they'll do is they'll just take a portion of the bowel. Now, I would imagine, I've never seen the surgery in real life, but I could imagine that this might complicate the surgery.
Okay. So I have another question in the chat book. As seniors with an SCI injury, what kind of urological tests should we have, and how often do you think we should have them?
That's a great question, and I think this is a question that, unfortunately, as a medical student, I'm not advanced enough to answer this. But I think a lot of these questions, because I don't want to be giving you the wrong information, but I'm actually writing them down, and I could maybe send an email to Duncan afterwards with my answers to this. I can provide resources to kind of the guidelines for the screening for urological procedures or a urological tests. I'm wondering if you think that would be appropriate, just because I don't want to be giving the wrong information.
No, that would be great. That would be fantastic.
Good. Just from what I read is that I think that it's recommended that you have at least an annual appointment with a urologist who will be doing the general exam. And if anything, and this would comprise of like a urodynamics, a pelvic exam, a cystoscopy, and then if they sense that anything may be abnormal, maybe they might have to run extra tests. But that is just my hunch. I'm more than happy to provide a detailed explanation and send it to Duncan after this presentation.
Okay, that sounds great. I have there's a thing there that it's a lot easier to clog a indwelling or suprapubic catheter, and I have to admit that I had those problems for a while, and then somebody, not a physician, somebody who has had a suprapubic catheter for a long time said to me, "Well, really." I said, like, how do you manage it for this long? He says, all you need to do is flush it. So what he means by flushing it, and what I've started to do is flush it, and I've had no problem since then. So you get a syringe that fits into the end of your catheter, and you just flush your catheter out, and it doesn't clog anymore. It's insane how well it works. And I have had no UTIs either since that time. So that's just me. Again, that's just me. It could be different for somebody else, but I think that, they should recommend that you flush any kind of catheter that you have, at least, I'd say once a week kind of thing. Lucas, have you ever heard anything about that?
I haven't heard anything about that. And just a question, when you're flushing your catheter,
Yeah.
are you flushing it? Oh, you're taking the catheter out and then flushing it and placing it back in.
No. I actually flush liquid water through the catheter into my bladder, and then it just pees out later. But it flushes out the catheter, and it puts clean water in my bladder for a little while, and that's it.
Okay, that's good. I think that's a good strategy. And I think because it's worked for you, I think that's amazing. I would just be inclined to maybe say that if your catheter looks quite dirty, or if you think that the buildup might be like bacterial, if it's like pink, you know how like if you're showering or in like your toilet seat, if it's like pink, I'm just inclined to say maybe flushing it back that into your bladder might be a bit risky, but I think it depends. And I think for you, what was the sediment like? How did it get clogged? Did it look like a stone, or?
It was like white sediment. White.
Okay, I think that should
and
be
it
fine.
it was pretty regular. It was like it was killing me. I was having problems like once a week almost. And since I started flushing, I haven't had a problem for 6 months now. Not one.
That sounds like that's just like calcium or like sodium.
Yeah, I don't think it was infected
deposits
in any way.
Is the risk of bladder cancer the same for people who intermittent cath versus indwelling?
I can answer that. I think that from what I found online, that indwelling catheters does increase the risk of bladder cancer. Similar to urinary tract infections, if you're reducing, if you're allowing your bladder to empty and kind of clean out more periodically in the method of like intermittent, I think that reduces the chance of infections. And I think similarly to with indwelling versus catheterization for bladder cancer, I think that indwelling increases the risk. I don't know why specifically, but I could maybe provide statistics over email after this.
Are the stimulation therapies only for people with hyperactive bladders versus hypo? And how can you access these therapies? Like, I noticed that all of the exception criteria was above L1 for all three of those studies. Are there ever studies that look at below L1?
At least the studies that we're conducting at ICORD, none that have looked at below. That's a good question. I'm just trying to see what I can find. Yeah, that's a very advanced question that I don't know the answer to. Do you have a injury below L1?
Yeah, and I have a hypoactive bladder, and I would love to try any of the stimulations. and I'm just not sure how to access it, like how to get into that system.
Yeah, because I
have...
think.
Oh, go ahead. Go ahead, Lucas.
Just to answer Megan's question, I think that the way that we're thinking that the stimulation works is by the electrical signals will reduce the bladder from being very hyperactive. We don't know exactly how, but we think that it reduces the rate of overactivity. Unfortunately, that if your bladder is atonic and not active, right now we haven't been able to find that stimulation can help with causing it to actually contract.
Okay.
Did you have it? And I would say that if you want to look into those kinds of things, do you have a urologist? Like, that's who you would talk to, I think.
Yeah.
Okay, here's another question. Is AD elevated, or does AD equal elevated blood pressure in urodynamics?
So AD, was this a question or a
It looks like
statement?
It says AD equals elevated BP in urodynamics. I'm not sure if it's a question or just a statement.
Well, it's Teresa.
Yeah.
It does for me, like when I go in to have urodynamic testing, my blood pressure goes up over 200.
Well,
and I don't know what to do about that. Like, because if they give me something to drop it down, then, and as if it's coming down, then you end up bottoming out at the other end, you know? So it's like, will it cause a stroke? Is my, well, like, oh my God, you know?
Yeah, so urodynamics does increase your blood pressure because you're filling your bladder quite rapidly. And some of the studies that we've published in the lab, one was a few years ago, looked at the effect of Botox in preventing the dysreflexia. Unfortunately, I think that if you're doing Botox during urodynamics, I'm not really sure how that interferes with the actual ability of the urodynamics test to measure how well your urinary system is functioning. Similar to the stimulation. But I think what we've been able to find is that Botox and stimulation can help decrease how high your blood pressure rises during urodynamics. So, but we're not at the stage where we can actually maybe implement that into urodynamics, because the whole point of urodynamics is to ensure that we have a proper idea of how your bladder is functioning. So unfortunately, that's where we're at. I think this might be a question to ask your urologist or doctor, at least in terms of the Botox, maybe not the stimulation. That's still at a very early stage.
You think maybe if it's a rapid filling of the bladder, if they filled it a little more slowly, maybe?
Yeah, they could fill it. They could fill it more slowly. That could help. However, then you might be in that position for quite a long period of time, which I know for a lot of people is either uncomfortable or just boring.
Okay. Now there's Teresa, I think you asked the next question too. Some people use lemon water as a prevention to infection. Is there any research on that?
Yeah. So I think that in that slide that I had with the mannose of cranberry, vitamin C, all of these have been thought to basically impact the ability of bacteria to form a film on your bladder wall. And I think that lemon would be similar in that it's increasing the acidity of your urine, and lemon also has vitamin C in it. So that in turn could have a similar effect. And I'm sure that there's been research that has been done out there showing it. However, I think it's kind of aligned with the cranberry juice that yes, some studies show that it has worked, but other studies show that it doesn't work. But in general, drinking lemon water is not bad in itself. So I think that if it makes you feel good and you think it's worked for you, you should keep doing it for sure, because it's not going to have any negative effects.
It wouldn't cause the stones either, like the cranberry.
Oh, that's a good question. Let me look that up for you. and maybe I can get back to Duncan on that.
Okay. I just noticed Lori's back. Lori, do you want to give us a little bit of a statement about your Mitrofanov?
Bet. I had mine back in, well, it's 2012 now. So it's been 13 years, almost, yeah, 2012.
2024.
Yeah, 12 years. Yeah.
Yep.
So it's, and it was a very major surgery. They had to use part of my bowel to enlarge my bladder because I had had an indwelling catheter in for so long that, of course, the bladder got smaller. So they had to increase the size of my bladder. So they used a piece of bowel, but the bowel doesn't know that it doesn't need to be secreting mucus anymore. So what happened is, or happens, is that there's a lot of mucus in when I catheter. There's a lot of mucus there, and sometimes it can be mistaken as an infection, where in actual fact, the count, because the count's a bit higher, there isn't infection there. So, I just have to be careful and make sure that I've got, the other symptoms of a UTI before I go and get antibiotics for it. But I've had absolutely no problem with mine. It's, been really quite freeing for me. Mine isn't right sort of under my belly button. It's down closer to my pelvic area. But because I had my appendix out, so they had to make the stoma from bowel as well. So it's but I mean, that when I had it done, it was actually very early on when they were doing them. It was actually a doctor, a pediatrician, who came to UBC hospital and performed the surgery with Dr. Nigro. So there was two of them there because apparently, from what I heard, they're performing them more on babies now that have spina bifida, which I do. And it's almost like it's a routine surgery, or was a routine surgery for babies. So like I say, it was a pediatrician who came in and did mine, but I got moved to Vancouver General after surgery because for some reason they couldn't care for me at UBC hospital. I can't remember exactly what it was all about, but anyway, I ended up down at VGH for about, I guess it was about 3 weeks. And the recovery was not a lot of fun. It was about 6 months before I was really back to what I would call normal. But after that, like I say, I have had very little problems with it and would recommend it for especially a woman who has a spinal cord injury. That,
Well, it avoids the whole transfer thing.
absolutely.
So you don't have to transfer onto a toilet to do self-catheterization.
Yep.
So it avoids that whole thing. It avoids a leg bag. You don't need a leg bag or anything like that. And it maintains your bladder size by doing self-catheterization. So it's a
Absolutely.
pretty good
Yeah.
option, I would say, but it is a major surgery.
Oh, absolutely it is. And I
Okay.
guess I didn't really understand just how major. Like I say, I was in Vancouver it was right at Christmas time. And because it had been put off since about September of 2012. But yeah, I came home, I think about 3.5, maybe 4 weeks after surgery,
Okay.
and was able to do the rest of the recouping at home.
Yeah.
So,
Okay. I've got another question. Jolene says, AD is a big problem for me when my bladder becomes too full. What therapies might help with this, and where would I look for help?
Yeah, so I think Teresa, someone asked a similar question earlier. If AD is a problem when your bladder becomes full, I think you should maybe ask your doctor about Botox. This would be injections of Botox into your bladder muscle. I think that we've shown in research in our lab that it can help reduce the number of AD events throughout the day. So if you're just wanting to reduce the AD because your bladder's full, then you should maybe ask about Botox. That's what I would recommend.
You said that the cystoscopies weren't really good at scanning or looking for bladder cancers. How do they scan for bladder cancer?
Yeah, what I meant by that is they're not very good at looking for bladder cancer, just because there's something called a false positive rate that basically every kind of test is not going to be completely perfect. In the case of a cystoscopy, you're looking up the bladder with a camera and you're looking at the bladder wall, and you might see a mass that you think could be potentially bladder cancer. And the actual chance that that is bladder cancer is not as high as we would want. But let's say if we saw something that we thought was bladder cancer, we would then undergo a series of other tests like biopsy. We'd have to surgically remove it. We'd have to put you on certain medications. And it turns out that that's not bladder cancer in the first place. So you're basically subjecting people to all of these extra medical tests when what we saw from the cystoscopy camera we thought was cancer was not actually cancer. Does that answer your question, Sean?
It does. It does. It makes sense. Yeah. Thank you.
Yeah.
Okay.
So that's why we don't do unnecessary cystoscopies, and only if your urologist sees that you're having like recurrent bleeding and you have a change in bladder habits, that's when they would then proceed with the cystoscopy.
Right. Okay. Thank you.
Okay. All right. What I really want to do is thank Lucas for what I think was an excellent presentation and a really good ability to answer our questions. You know, he's not a urological surgeon yet, but he certainly knows a lot of the answers already. So he's probably on his way. Thanks, Lucas. Okay. And I will forward any of the answers that we said we didn't have answers to yet to everyone. I'm trying to get our tech support to create me a group email list right now, and that should happen this week. And the thing that I want to announce is that at the Blessum Center on Thursday, March the 14th, there's going to be a research roundup at the Blessum Center in the atrium on spinal cord injury, a spinal cord injury research roundup. I think it goes in the late afternoon from 5:15, but I can send the announcement again out if anybody wants to go to it. Okay, that was the one that I really wanted to mention. This has been recorded, and I will put it on our Aging with SCI spot on the SCIBC website. So that if anybody wants to review it, they can.
Great.
And Lucas is fine with that. If you have more questions, you can always email me, and I can forward them to Lucas. And thank you all for being here and asking great questions.
Thank
Okay,
you.
next month, we're going to do physical activity with aging and SCI. So in the discussion group, we'll raise a bunch of questions, and I have Jasmine Ma from UBC to do the presentation. So thank you very much, and I look forward to our next discussion group too.